and then take that back to the main room to report back. I'm just going to give a little bit of an overview of what we're going to do. Then I'm going to invite my other two co-chairs to speak before we move on to the main speakers. So we've heard a little bit about the call for a social care people plan this afternoon already. We've heard some of the comparisons with the NHS people plan, and we've also heard what potentially the white paper might do in terms of thinking about what an integrated workforce plan might look like across health and social care at an ICS level. But what do we really want from that in the context of new ways of working? One of the things that's really struck me during the pandemic, working extensively with members from across all different forms of provision of social care, is just about the new level of skills and expertise that staff have developed during this pandemic, and not just that those skills have been that those responsibilities have been thrust onto people during the pandemic, some of which is true, but also that there's been a real embracing of that and a chance for people to step up and show the expertise that they have. And I think we talked a lot about the kind of recognition that the social care workforce has had during this period. So if we have a social care people plan, do we need it to really recognise those skills and experiences that will enable us to sustain and continue the workforce transformation that has been going on? And does that workforce plan need a commitment to provide the kind of information, support and training to unpaid family carers and friends, and also have a kind of commitment towards long-term volunteering? And finally, I think, and interestingly, in the context of the white papers name in relation to innovation, do we need this people plan for social care to particularly look towards how the education and training of social care skills people up for future delivery? It's been very difficult, and it remains very difficult, I think, to think about some of the kind of funding reform agenda and indeed the people plan agenda without setting down that real vision for what social care will look like in the future. But I think we can look back on what the transformation in social care delivery and the skills and expertise that staff are required. If we look back 10 years to where the skills and expertise that are required now, we could have a pretty good stab at looking forward to the future and recognise we will need different skills, expertise, particularly in the context of digital, but also in terms of supporting and caring for people with ever growing needs of complexity and comorbidities. So do we need to make sure, and how do we make sure that that people plan for the future, the people plan properly incorporates the kind of education and training pathways that are needed for the future? So I think that's just a sort of some opening thoughts about how we get our head around new ways of working and delivering social care, and how we get that into any kind of people plan going forward. But I wanted to invite Alastair to comment as one of the co-chairs and a member of the advisory group, what your thoughts are in relation to this.
Just checking my. Thanks very much. Thanks very much, Vic. I'm delighted to do that. My name's Alastair Henderson. I'm the Chief Executive of the Academy of Medical Royal Colleges, which is, almost as it said, it's the membership organisation for the different medical royal colleges. So very much has a focus on the NHS, really. But interestingly, I think medical royal colleges have, over the last 3 years, been increasingly recognised and increasingly public about their support for social care sort of reform. And I think that's for two reasons. One has been as we talked about a bit earlier, a sort of growing recognition of the value of social care as itself for what it does and its own importance that I think we all recognise has been undervalued sort of before, but also from a bluntly slightly more sort of selfish point of view, an absolute recognition now from the health service, from doctors' point of view, that if social care isn't working, nor is the health service going to work. So I think that's why what the interest has been. I think I have to say, probably straight up that I do not pretend to be an expert on social care workforce issues, though I have a reasonable understanding of some of the NHS workforce issues, both sort of from my current work and previously where I was at the NHS Confederation and NHS employers. But I think what I was just going to bring up was, I think that it is quite interesting, some important lessons, I think, from the approach to workforce sort of in the NHS, and particularly the stuff around the people plan that has been talked about. And the sort of slogan of the NHS people plan is more people working differently in a compassionate and inclusive culture. And that strikes me as a pretty good set of things that can absolutely equally be applied to social care. I mean, at its simplest, that was around before then, I mean, bluntly, happy staff equals, in NHS terms, happy patients. It's fairly straightforward. It happens in lots of sort of areas. If there is lots of evidence that good staff engagement, staff who are satisfied in their jobs, will provide sort of better service. And many of the health services best performing organisations are the ones that where staff are most engaged, are most satisfied sort of in their work. And that is not a finding exclusive to health service. It's not a finding exclusive to as a public service. It's a finding across sort of employment. And that strikes me as sort of huge, sort of important, and one of the things that needs to be a basis that we think about what are we doing in a people plan about engaging staff, about ensuring that their commitment to that. Just really a couple of other things I wanted to mention in our under sort of our heading. This is about new ways of working, which I think is important. I think that there has been in the health service a degree, probably from professionals and other staff, of like anxiety about heading new ways of working. Does that mean, what does that mean? Is that something that people should be anxious or afraid about? My view and my experience is that no, it shouldn't. Change isn't always comfortable, but on the whole, it's about engaging people, about providing a better service, about allowing people to get more out of their jobs and out of their roles. And I think taken like that, when people do embrace that sort of new ways of change, it can actually be hugely rewarding. The process of taking people through that new ways of working is really important. People have got to feel they are part of that. Otherwise, they will be anxious. They will think that this is a threat to them and their jobs. And what strikes me, what I always say in the health service, there is plenty of work to go around. And the same strikes me in healthcare. It's not that we've got a shortage of things to do. The final thing I just wanted to talk about was in our sort of heading there was about retention of staff, which just strikes me as absolutely sort of crucial. And the health service has been possibly slowish to learn this. I mean, it's the classic thing, you know, there's not much point in turning the taps on in the bath if you've got the plug out. And the first thing you need to do is actually put the plug back in. Massive turnover of staff, which I know is a big issue in social care, is not good for organisations. It's not good, particularly for individuals. But addressing that retention, you know, has benefits all the way around in terms of, you know, better staff engagement, better staff morale, and better sort of attachment to the organisation and better sort of service. So I think it's those things, picking up those things, making sure you engage staff, making sure that we retain staff, making sure that new ways of working is an opportunity rather than a threat. And that's what I just want to say to start with. Okay,
look, thank you, Alastair. That's great. And I think whilst you're saying you don't have lots to say in relation to social care, I think that read across from the experience of health is hugely important and something for us to think about. Stephen, did you want to add anything?
Can I just very briefly add a couple of points, Vic? Firstly, I do want to build a little bit further on this point of the parallel between thinking about the NHS and the NHS people plan and social care and the social care people plan, because politicians who've had responsibility for the health and social care system, including myself, have, it seems to me, repeatedly, including actually today, fallen into some fairly obvious traps, because what happens is they stress, I have stressed, they stress the importance of thinking of health and social care as a single coherent service. And that's the daily experience of people, in particular working in community health services, in social care, in primary care. And it's the daily experience of people working in the hospital service when the linkages don't work, either because the wrong people appear in hospital or because people who don't need to be in hospital are unable to leave. So right across health and care, the experience of the people who rely on those services and the experience of the people who deliver those services is that there is a single continuum that ought to be thought about as a single continuum. And the politicians, when talking about policy in this area, talk about integrated health and care services. That speech is written into every minister, every Secretary of State, that paragraph is written into every Secretary of State speech. But it's a paragraph. They then turn the page and then they talk about funding for health and funding for social care, recognizing that there are differences, but ignoring the obvious links between them. They talk about staffing in health and staffing in social care as though they were two different things. In recent years, the phrase has grown up within the health service, which I'm in favor of the concept, but if you stop and think about it for a second, in a sense, it's an absurd concept of social prescribing. The idea that problems don't always have medical solutions, and that you may be able to do more for an individual by engaging with them about their social context. The only thing I disagree with about in the concept of social prescribing is that you should go and see a doctor to be told that you ought to take more exercise or engage in social activity. So what the point I'm making is that we talk about integrating these services, but at the most elementary level, we don't follow it through to a conclusion. And this whole area of staffing in social care is a perfect example of that failure to think the issue through. It usually comes as a surprise to my former colleagues in the political world when you say that in the single health and social care system, you ask them how many people, what proportion of the workforce do you think works in the NHS, and what proportion works in social care? And they tend to think, oh, the majority, probably the large majority, work in the NHS. It's actually wrong. There are more people work in social care than do in the NHS. And yet we develop a people plan for a single health and social care system that only addresses a minority of the people who work in it. So it's worth just reflecting on that when we talk about the importance of a people plan. The other point I just want to make before and then go to our principal speakers, and I'm sorry to be the principal speaker, sorry to make this point. The danger is we think that this is an issue of support for elderly people. Actually, the fastest growing section of the social care sector is services for working age people. So as we think about ensuring that we have the staff that we need to deliver joined up services, let's for goodness sake think about the problem, the issues that need to be addressed, and move on from thinking that reflects the services of 20, 30, and even more years ago than it is since I ceased to be Secretary of State.
Okay, thank you. Thank you very much, Stephen. And I think I'm remembering the attempt at a joint plan, which was about 2017, I think the most recent attempt at a joint health and social care plan, which was about 100 pages of health and about 5 pages of social care, most of which appeared to suggest it wasn't a great place to go and work in social care. And then the two plans were decoupled once again. But apologies for those who've probably got a better recall of it, but I just think it's interesting to note that we haven't given up sometimes doing that, but the reality of then looking at it. And I'm sure our speakers will emphasise some of the very fundamental differences that make it impossible at this moment to do something together, which particularly around the kind of level of funding and investment in social care workforce and other areas. I just want to pick up on your point, Stephen, about the growth area, and I think is absolutely important. This isn't around kind of only around older people. I think from a workforce point of view, I suspect the older people's workforce is still large. The people working with older people is still a larger cohort, but from a cost base and from a kind of funding and financial challenge, I think you're absolutely right that we've got now a very bigger and significant growth in terms of the cost base around working age adults. But the expert on all of this, who will be able to get right all of the figures, is our first speaker, which is, I'm really delighted to welcome Oonagh Smyth from Skills for Care, Chief Executive, to talk first of all around these issues. Oonagh.
Thank you, Vic. Yes, as Vic says, CEO of Skills for Care, the skills and workforce body for social care. And I thought I was going to take my lead from Andrew Dilnott and start off on a positive, and I'll move on to some of the challenges. But I really do think that there's an opportunity to change the narrative around social care as a career and the workforce, and to welcome and value social care as being at the heart of our communities, but also to think about social care as an industry, a really significant industry in terms of our economy. It adds 42 billion to the economy of the UK every year, and that means it's going to be absolutely key to economic recovery coming out of COVID. And yes, I think there is a moral argument for having a social care people plan, but there's also a real economic one, and I think that does change the context of a workforce strategy. That's not to deny, obviously, that there are challenges, and most countries in the world are looking at how we meet our changing needs. The fact that we're living longer, which is wonderful, but not necessarily healthier, and that we're going to need more support, but also different types of support in the future. So looking at what we need and making sure that we are future-proofing that, as Vic said, and thinking about how we build that now, because some of that isn't quick. So some of you might know that Skills for Care runs the adult social care workforce data set on behalf of the Department of Health and Social Care, and that gives us really helpful benchmarks, and they've been referenced quite a lot today. It covers about half the workforce, so about 700,000 people, and gives us a depth of insight into the current workforce. And I think what it tells us is that we had a system that was already under strain before the pandemic, and now there is additional pressure. And what that has also meant is that people are having to work harder, but they're also having to develop very new skills and do different types of work. And they're going to need different skills to do that, like Vic mentioned at the beginning. So we at Skills for Care estimate that there's about 7.3% of roles are vacant in social care, and that was last year. And just to put that in context, that means every single day there's 112,000 vacancies in social care. And it's true that about 2/3 of people don't actually leave the sector when they're moving around jobs. They'll stay within social care, but that gives a sense of the amount of effort it takes to fill those thousands of posts every day. We also have a significant turnover rate in the sector, so about 30% turnover, and that masks some higher rates. So registered nurses, the turnover is 34%. And that gives us some sense of the short-term challenges that we have, but then just thinking about the long term that a strategy would need to address. About a quarter of our workforce is over 55. And so that means that about a quarter of our workforce might be retiring in the next 10 years. And our turnover rate for the under 40s is 40%. And that tells us a story, I think, about the pressures that we're feeling and we're going to continue to feel. And then just looking ahead at the projections for the workforce, by 2035, we're going to need about another 520,000 people just to keep pace with demand and demographic changes, unless there's some significant change. And so we can see that that's telling a short-term and a long-term story that any strategy is going to have to address. We've also found more recently with COVID, so looking at data from care homes, particularly from March and August in 2020, the occupancy rate has fallen from 87% to 79% in care homes with nursing, and 87% to 82% in care homes with nursing, without nursing, sorry. And so that's adding to the pressures in the system, but also is giving us a sense of how care might be changing in the future. We've talked quite a lot about pay today, and so the only thing I'd quite like to droid is the fact that increasingly as a sector we're becoming a more of a minimum wage sector. So with the national living wage, a higher proportion of our staff are at that minimum, and the pay differentials between different sectors are reducing. So it used to be maybe 10 years ago that care workers were paid more than people in retail, and now they're paid about 24p an hour less than people working in retail and sales, and then obviously that has impacts in terms of keeping people in the sector. So just thinking about what any plan would need to cover, I think recruitment and retention will have to be thought about. So thinking about how we find a way to bring new people into social care, to make social care more attractive to people who might not normally think of social care as a career. And the one that always sticks out to me, which people who speak to me are probably bored of me saying, but men make up 18% of the social care workforce. And so is there a potential to start to think about how we attract more men into care roles? We're notoriously bad at keeping younger people in care. Is there a way that we can be better at that and work out how we attract and keep more younger people? We know that investing in development reduces turnover. So if you train somebody, they're more likely to stay. The more you train them, the longer they stay. And so I think there's a real story that the evidence is telling us. And I also think that we need to recognise in any strategy the support that people working in social care now need in the future, thinking about the trauma of the pandemic and the weight that people are carrying. We're at risk of losing a lot of very experienced staff with exactly the values that we need. But I think we really do have a once in a generation opportunity just to work together in partnership with central and local government, people who draw on care and support, employers and others in the sector, so that we can think about a sustainable plan for the social care workforce. And I really do believe that taking a partnership approach is going to be key. I think we need to develop a plan that starts from a vision of what we're trying to achieve and puts people drawing on care and support at its heart. I think we need to plan built on data and insight and what we know works. We need to be clear what the different roles are of everybody in the system. We need to think about career development pathways and the skills that we need now, but also in the future with changing needs, digital skills, prevention skills, more specialist skills. The roles are changing and we're not always keeping up. And I think fundamentally we need a strategy that recognises and values the importance of social care in our communities now coming out of the pandemic, but long into the future as well.
Brilliant. Look, thank you, Oonagh. That's fantastic. And I see a request in the chat for some of the stats that you've been providing there to share them. And I'm guessing it'd be helpful if you maybe could just share the state of care or size and structure reports would be really helpful. Thank you. That's so helpful to get that real granularity of information coming out of that fantastic data set that's kept. And also, I just think we might talk about future skills and future requirements, but I think you've given us the really timely reminder that we have got an aging workforce, and that unless we address that very specifically as well, then we will have, we'll be adding further pressure to the way in which the social care workforce can deliver care going forward. I'm going to move us on now to John Rogers, who's here as the Chief Executive of Skills for Health. John, do you want to pick up the baton around?
Yes, thank you very much, Vic. I suppose, like Alastair, I come very much from health. I've been Chief Executive for 20 years or so, rather longer than I expected it to be. But in those times, I guess there's been an awful lot of collaboration between Skills for Health and Skills for Care. So in the past, we've done
joint national occupational standards. We've done joint work on NVQs, if everybody can remember those. We've more latterly certificate in care, etc. And a lot of that work is actually focused around the support workforce. And I suppose I was interested in listening to the debates earlier in terms of saying, should this be a social care workforce plan, or should it be a joint health and social care workforce plan? And I guess where I come from is that if we're going to achieve effective joined up services and effective collaboration, it should ultimately be a joint health and social care workforce plan. Having said that, I do listen to all the other comments on the call, and they are perfectly valid in terms of when Christina was doing the introduction and saying out of the 142 pages, there was the several paragraphs on social care, or latterly, I mean, the same comments have been made. But in a way, is that a good reason for not having a joint health and social care workforce plan? Because what it's saying is we haven't done it very well in the past, and therefore that's not a good thing to do. Possibly the answer is somewhere in between, in terms of saying it might be both, because it might be saying, yes, we definitely do need a social care workforce plan, because if you don't have that, you don't have the true focus on social care. But how do we get to that middle ground in terms of saying, how do we really get a joint health and social care workforce plan, which is not 7 pages of one and 130 of the other, and how do we actually build that? So I think that would be a challenge for me from where I sit in terms of saying, how do we take that forward? And I think, I mean, some of these things have been repeated already, but, you know, with the pandemic crisis, there has been more joined up working than ever before. And I think there's been a greater realization in terms of the benefits of that. So I would pitch that as an opportunity rather than saying that things are difficult at the moment, etc., which undoubtedly everybody knows that that's where we are. So in terms of, I think we are at a time of will and momentum, and you know it's written loud in the white paper again today, in terms of saying, how do we get a real step change in better integrated working across health and social care, and how do we benefit our patients and clients by doing so? And essentially, I mean, the barriers are pretty obvious in terms of number one is finance. And that's been writ large in terms of some of the presentations today. The next one would be around how we look at service redesign. And I think there's a lot of experience within that now. And then the third part is how do we get better workforce integration, better workforce redesign in terms of how that joint working works and how it works across the system rather than independently. Of those, as I say, nothing really happens without the finance first question, because if we can't get that part of it right, then everything else becomes very difficult. The other thing, just to throw in terms of the conversation, maybe debate today, Vic, is to say, how does local workforce plans link with national workforce planning? Because I know that, again, there's been comments on this forum today in terms of saying ICSs tend to be too health focused, etc., etc. But there's some really, really good work being done within ICSs and ICS workforce plans in terms of looking at collaboration, looking at joint working, etc. And just this morning, in preparation for this session, I was having another scan through the West Yorkshire and Harrogate Partnership Workforce Strategy, which is a really, really excellent strategy in terms of building those links across. And certainly if we were able to materialise that in terms of deliver that for patients and for clients, it would have a really huge impact. So is there a relationship somewhere in terms of saying, how do we get the national perspective, but where things really happen at the end of the day are within health communities? And that's got a lot to do with how humans interact across systems and how people collaborate and work together on a leadership basis. And I think there's a lot of work to be done in that area in terms of saying, how do we get that better? So, I mean, that's certainly the areas that we've been working in terms of some of the local health systems. And certainly there is a lot of willingness, a lot of really kind of joint direction to say, yes, we all know that this is the direction that we want to go in. At the end of that, it's a huge change management challenge. We've got to get the finances right first. We've got to get other things right. But I think it's a goal worth actually reaching for in my book. So looking forward to the discussion and debate today, Vic. Thank you very much.
Thank you. Look, thanks, John. That's great. Philippa, I'm going to move quickly on to you. Particularly, Scotland's just had a new review paper across all of those areas that John's talking about in the context of finance, service redesign and workforce redesign in a way. So it would be very useful to hear what your thoughts are around this challenge.
Thanks very much. I'd like to start by paying tribute to care staff for all they've done during the pandemic and recognise that they too have often felt bereaved when they lost residents they'd looked after for a long time, but instead of sympathy often faced criticism and attack in the media. Unfortunately, the pandemic did come at the end of a decade of austerity, and service cuts and low morale had led to vacancies and understaffing, but also to under-provision. Age UK estimate that it's well over 1 million people who are not getting the support they need. Scotland faces the same issues of an ageing population, a growing need for social care support, and the challenge of retaining and recruiting care staff, particularly with the new visa requirements increasing the difficulty in recruiting from the EU. However, there are significant differences in both the provision and structure of health and social care in Scotland. And one challenge that we do have is that Scotland is 1/3 of the UK landmass with over 70 inhabited islands. So we already have significant digital and telehealth infrastructure, which we then were able to roll out more widely during the pandemic. But after devolution 20 years ago, the structure of the internal healthcare market with hospital and primary care trusts were reversed in Scotland, and the Scottish NHS returned to being a single public body with local services provided by geographical health boards. This obviously sounds quite similar to what Matt Hancock described this morning with integrated care systems, but obviously the devil's in the detail, and we'll have to just wait and see what emerges. Scotland is unique among the 4 nations in funding free personal care and has provided this to those over 65 since 2002. However, the age threshold was removed in April 2019 by what's called Frank's Law, named after footballer Frank Coppell, who developed early onset dementia. And this comes back to the point made earlier that we often think of elderly people when we talk about care, but actually there's a significant working age population who require care support. But this kind of free personal care provision encourages people to stay at home, which is what most of us would prefer. And 2/3 of our social care is provided in people's own homes. It means there's the need for a strong home care sector, but also that those in care homes tend to therefore have much more complex care needs. Scotland has been working since 2014 on integrating our NHS with social care through the establishment of integrated joint boards. But of course, COVID has highlighted just how much further we have to go. It did, however, stimulate a lot of close working between health and social care during the pandemic, including a project I was part of when I went back to the NHS during the first wave. This involved clinicians from acute medicine, geriatrics, and the local hospice being available for on-call advice, but also holding regular Zoom meetings with care home staff to discuss difficult cases and provide training in symptom management and end-of-life care. Having been involved in many redesign projects as a breast cancer surgeon, it was quite striking to see the usual barriers to innovation simply collapse. And the relationships developed during the pandemic will definitely accelerate integration going forward. As well as providing PPE to local social care providers and indeed to unpaid carers, health boards offered access to NHS bank locum staff to help ensure safe workforce levels, along with more community nurses getting involved in working to support care homes. Even more than healthcare, social care is delivered by people for people, but both user and staff can get mangled by a system if it doesn't recognize the importance of relationships and the need for continuity, dignity, and respect. Part of that recognition is simply that care staff should be valued and paid properly for a tough job. The Scottish Government has funded the real living wage for all care workers in Scotland since 2017. They now fund overnight sleepovers and provided a 3% pay rise last year. They also undertook to underwrite sick pay during the pandemic to ensure that staff in care homes who were infected or were contacts were able to isolate. And this month, social care staff in Scotland will receive the same £500 thank you payment as their NHS colleagues. Care staff require respect and shouldn't be described as unskilled workers, which I often hear at Westminster. We need to aim to make working in the care sector a career choice, with the possibility of further training and career development, not just a low-paid stopgap before someone is attracted away to better pay on the checkout at Tesco's. However, it isn't just about basic pay rates. It is about overall terms and conditions and the ability to take pride in one's work through having that ongoing satisfying relationship with the person receiving care, not just a 15-minute transaction. As you mentioned, in the autumn, the Scottish Government commissioned an independent review of adult care in Scotland, which was published last week. This proposes the creation of a national care service with national contracts, standards, training, and terms and conditions to try and ensure greater equity and consistency for both the staff and the care recipient right across Scotland. It promotes a human rights-based approach to the care recipient, with the principle of considering social care an investment in allowing all of us to be included and to participate actively in society, rather than just being considered a burden. It's already been referred to that we should be celebrating that people live longer. People often say, oh, you know, everyone is getting older. But as a breast cancer surgeon for over 30 years, no, not everyone is getting older. Many people never reach maturity. Many people never reach old age. It is something that we should celebrate, but we do actually have to make sure that those of us who do live longer, live well, live healthy, and live with dignity. Many of us will be part of the next generation of care users, whether as a direct recipient of care ourselves or as an unpaid carer seeking respite for a loved one. So we all have a vested interest in reform of the structure and provision of social care, but particularly in how the people who will care for us and our loved ones are valued.
Thank you, Philippa. That's really useful to hear the experience of Scotland, and particularly I hadn't recalled that the Integrated Joint Boards had been around since 2014. Working closely with colleagues in Scottish Care, know how important not only the boards have been, but also the investment in the infrastructure to enable social care to have a proper voice at the table of those boards. And I think, you know, that leads us on to some kind of important discussions about not only just looking for some parity around both having a plan, but actually recognizing that you can't, part of the challenge of having a joint plan is because there isn't a joint approach towards investment or indeed recognition in that way. So
the health and social care partnerships and boards are now responsible for disbursement of basically half the NHS funding, the NHS social care funding. So it does allow them quite a lot of flexibility to look at the needs in their community and to invest in some of that preventative work that all of us know should happen, but often we never quite get around to.
Absolutely, absolutely. Okay, well, look, thank you. And apologies, right at the beginning, I didn't introduce you fully, but for those who haven't gathered, it's Philippa Whitford, who is the SNP spokesperson for health. So fantastic to have that insight and something for us to think about as we respond to both the white paper, but also the immediate challenge around how we think about a social care people plan. So we've got about 15 minutes left, just under, for some questions or comments. I can see that there's a few things that have been raised in the chat in relation to people agreeing with your perspective, Stephen, around the experience on the ground. You've described a lot of warm words around integration and a very different experience for those who are trying to work day to day and find themselves willingly or largely unwillingly within silos and unable to reach out across boundaries, and some reflections in terms of the different levels of need that are out there, an unmet need that's going on at the moment. So just how urgent I think a lot of this focus is. What I'd like us to do is, I can't see any specific direct questions in there. Here we go. There is one here, apologies. From Angela. Alarming lack of knowledge about social care and especially social care for adults with learning disabilities in the department. Angela, do you want to sort of pose that question?
Could I actually, hi, it's Angela Buxton from NCAP. Could I actually ask the question I just posted?
Okay, you can ask both if you like. You're in a luxury position of having the opportunity to be on speaker and go for it.
Yeah, so my more recent question, I think the other one was more of a statement, is do the panel think we need a professional sector body akin to those we find in health, which ensures that people using social care are brilliantly supported, cared for, by setting standards for the way care workers are educated, trained, paid and monitored throughout their careers? So
an NMC type equivalent, is that yes. What you're thinking of, that sort of Nursing and Midwifery Council type, so somebody with oversight of regulation and others. Oonagh, did you want to pick up on that? And it'd be useful just, we didn't talk, I don't think Philippa mentioned around regulation of the workforce, but obviously that's in place in Scotland as it is in Northern Ireland and Wales as well. So would that be part of your people plan perspective for the future, and alongside Angela's idea about that having a role around regulation too?
Yeah, I know Angela very well. We worked together for 8 years in MENCAP, so it's lovely to see you, Angela. It's interesting because it came up in the last discussion as well, where people were asking around comparing Wales and the registration in Wales, and obviously England is the only country in the UK that doesn't have registration. There is a scale issue. So obviously we've got 1.6 million people working in social care, and that's a huge scale in terms of the cost that has to be considered. I think registration could be an important part of a long-term people strategy, but it wouldn't. I wouldn't say it would be valuable in and of itself. I think it has to be part of a wider, bigger picture, a longer-term picture, thinking about how we build and understand the skills, the qualifications, the career development of the workforce, and invest in the workforce. So I think it could be part of a longer-term strategy. I think we'd have to do more thinking the devil's in the detail and all of these things, in terms of where the cost sits, the scale of that, and whether we would choose to put resource there and not somewhere else. And I think that's the tricky conversation that we'd need to have, I think. Do we have a sense? I mean, often cost is cited and scale, and
you know, but I mean, there is a large scale regulation of many roles within health. Do we have an idea of what this would cost? I mean, is that something Skills for Care has kind of scoped out?
No, it isn't, but I think because there's so many different models for it, it depends on, I think, the level of regulation or registration, whether it's light touch or not, who pays for it. So the models are also different. And I always go back to us being very clear what we're trying to achieve and what problem we're trying to solve, because sometimes registration can be seen as an answer to everything. And I think just being really clear what the driver is will allow us to say, well, is that going to achieve it and is that proportionate? But yeah, I mean, if you look at some of the different models of registration, they are also different in terms of the charges and the cost models.
Sure. I mean, it's interesting in the COVID context, and maybe in the white paper context, one of the big challenges has been the lack of a register has made it very difficult to communicate directly with care staff. And I wonder whether the sort of push for more centralised data might be a way to think about incorporating a register within that context. Alastair. Sorry.
I was just going to say, and if that was the driver, if it was to understand more and be able to communicate more with people, then that's one outcome. Another outcome that people talk about often is around public confidence, and I think that would drive a different model. Or if it was about professional development and skills development, again, that's a different model. So sure. For me, it's just about being really clear what we're trying to achieve.
Great, yeah, Alastair, and then Philippa.
I was just going to make.
Sorry, Steve.
I think sort of on Angela's question, I mean, in health, from my perspective, the landscape is actually in these areas that you talk about standards, sort of education stuff, is fairly complicated in across healthcare, because you've got, as was being talked about here, there are the professional regulators, whether that's the NMC or the GMC or wherever. You've got statutory education bodies, which is Health Education England or NES in Scotland. You've got professional bodies like my members, sort of colleges who set standards and stuff as well. So it's, I think there are a number of people in healthcare who are saying, you know, if you were starting again, you wouldn't necessarily start from here. So I think there's a question of, you know, what is it you wish for, etc., of working out, I mean, of what's the right thing that doesn't have over complexity, but gets the right thing. And I'm not sure I know what the answer is, but it's not necessarily just sort of following what happens, sort of, you know, the slightly complicated picture in health.
Thank you. Sorry, Stephen had got his hand up. If we could quickly have Stephen and then Philippa, and then we'll move on.
Yeah, I just wanted to come in actually in support of both what Oonagh and Alastair have said. That I think the danger with the registration argument is that it becomes a substitute for thinking through what it is we're trying to do. Be careful what you wish for. It's what are the terms for going on the register? Very, very importantly, what are the terms for being taken off the register? Because when you remove, are you removing the individual's right to earn a living when you take them off the register? That's something that can't be done lightly. And so I'm not against extension of the registration principle, but I'm very mindful that, for example, the NMC has had its issues in recent years, and be careful what you wish for and be very clear what you're looking for would be my suggestion.
Okay, now Philippa, you don't have to wish for it, you've got it. So tell us all.
I think the key thing is really about training, and then the recognition of that training and the ability to develop. You know, if you go into a job, even if, as here, you're paid the real living wage, if you're going to be doing that job for 20 years and you can never move up, you can never be challenged, you can never develop, then it's still a dead end job for you. And that's one of the things that we have to change. It's the training. And I think what that brings with it is respect, is recognizing that social care is a profession and is a career. And when you think of two of the big innovations in the NHS in Scotland, which was the Scottish Patient Safety Programme and the clinical outcome standards, that involves all staff being part of data collection, being part of analysing why things go wrong and how you put them right. So you need to have access to the staff within social care, because that is one of the recommendations of the National Care Review, is to be looking at carrying over some of this quality and safety approach that's, you know, bread and butter for us in the NHS, but to be putting it in social care. And therefore staff need to have training both at the beginning of their careers, but also throughout their careers.
Great. Okay, well, that's interesting, and that stems into, I've got 3 more questions, and I'm just going to very briefly summarise them and invite the panel, all of you, just to have a very brief response, because the clock is ticking and we'll all be booted out if we're not careful. So a couple of the questions are about the future. So do we know the roles and skills we'll need in 10 years' time? And assume that they will look different, and have we got a kind of clear enough picture of how different they will look? A question about attracting younger people into care as a career. And finally, a question which perhaps reflects on the whole premise of a people plan, in a sense. One to say, what mechanisms do the panel think there is for actually making changes to the workforce, when essentially social care is delivered, certainly in England, in the context of a market with lots of individual employers who have you know, legal duties and responsibilities over staff? I mean, is there a role for a centralised approach towards this? And if so, is the answer about funding, or is the answer about kind of ministerial responsibility for workforce planning and delivery? So John, can I come to you first? You haven't had a chance to respond. Do you want to pick up on any of those particular issues?
Yeah, I suppose in terms of my area of knowledge, Vic, I'll stick to that in terms of, as with Alastair, pretending any other wider knowledge of social care. But I think in terms of saying what skills do we need in 10 years' time, I think probably the answer to that is nobody 100% knows, because as technology advances, etc., etc. But the part answer to it is, how do we stay flexible with the workforce? How do we actually maintain a base and have a workforce that can actually develop over time? And the obvious answer from an education perspective or a people development perspective is probably a more modularised approach, which actually interestingly links to some of the education white papers coming out over recent days in direction forward and localised division around that. So I think it's more of the staying flexible and the approach to it, rather than trying to define now what we need in 10 years' time.
Wise words. Oonagh, what do you think? Anything about getting young people in, or?
Yes, so I think the list that Caroline has given in terms of the balance of skills, I think I would agree with all of that, and I would add we will also need to think more about skills around prevention, which I think I said in my presentation, and just thinking about thinking of skills beyond the health sphere, because not everybody who draws on social care also has a health issue. They might the interaction might be with other systems, might be the employment system, or and so just thinking beyond social care through the lens of health, I think will be important. And I've forgotten your last question, Vic.
It was really just about young people.
Younger people, yeah. So 40% turnover within the first year for younger people. So I think we definitely do need to do something. Some research suggests that younger people are more attracted to roles where they can understand the level of autonomy that they can have in decision making, building direct relationships and the depth of relationships that you get to build in social care roles. And I think we need to be building more on that. But I also think having clear career pathways and development opportunities for younger people. I think flipping the narrative around social care will help for that as well, because the crisis narrative and it doesn't necessarily attract people into social care, I think.
Okay, thank you very much. Now I can see the clock ticking down, so what I'm going to do is say a big thank you to all of our panelists and my co-chairs for this session. Stephen is going to, when we get back in, he's going to be responsible for summarising this discussion. And you're still on mute, Stephen. But what also you might want to do in your summary was, I guess, answer that question of whether we've got a right to do this. You know, where that responsibility sits. Is it with the individual employers, or is it government that should be levering the way that the workforce looks in the future? So big thanks to all of the panel, and thank you very much for everybody who's contributed. And it looks like the breakout room is closing, so you probably have now got a message that's come up to invite you to leave the breakout room and return to the main session, where we will be in Stephen's capable hands to feed back on this fascinating session. Thank you.
Thank you.
Will you let me know when everyone's, or nearly everyone's back, Emily?
Yeah, they're making their way in now, so feel free to start.
Oh, great. Okay. Well, welcome back, everybody, to the plenary session. I joined one of the